Hi guys, this is Charles and I'm one of the surgeons at Southpaws. Today we are going to do a nasopharyngeal stenosis in a cat presented with really severe nasal signs that have been present for about a year and a half. And so we're going to do a ventral rhinotomy and hopefully open up the stenosis. Now you can see on the CT scan that's alongside of the video that inside the green circle is the stenotic lesion. You can see two webs that are present. We tried to get a balloon and a scope through, or we tried to get a balloon through a scope through the stenoses, but we couldn't get the scope through, thread through the two narrowed regions. So we're going to go in ventrally and try to remove the webbing, and then we'll probably start some corticosteroids and hope that the stenosis doesn't recur. So this isn't an entirely sterile surgery. In fact, it's not sterile at all because we're working inside the mouth, inside the nose and stuff. So I'm just putting drapes on because I like blue and just to kind of make me feel better that we're doing a clean procedure here. So if you haven't subscribed to our channel, please do so, and don't forget to turn on your notifications so that the next time we have a live stream, you'll get a little ding on your phone. We have the live chat running, and if you have any questions, please feel free to ask. Look at the soft tissue kit, please. We'll run through our pre-surgical checklist. So first thing is the ground plate connected? It appears to be. Second thing is confirmed slide and procedure. So we're doing a ventral rhinotomy in this cat. I'm going to confirm our instruments. So we're going to use a neurodrill to potentially go through our hard palate, although, you know what, I don't think that we need the neurodrill just to start with, because I think we're quite a fit far caudal to the hard palate, so I think we can do it all just with soft tissue instruments. Then Gelpia retractors to open up the airway. And the thing with this cat that we need to be careful with is that we're not retracting the mouth too far open because you can have issues with the carotid artery. What do you need, Beck? The artery is this side. Okay. There you go. And so we've got the cat obviously in dorsal recumbency with the mouth now pulled open, just not too far. And my hand, unfortunately, just given the positioning, is going to be in the way when I'm operating, but I'll try to open up or I'll try to move my hands periodically so you can see what's going on. So I've got my suction off the side of the table there, guys. Get that connected. Let's grab some towel clamps just to secure the drapes. And can I get a 15 blade, please? Or actually, you know what? A 12 blade would be great. All right, so I'm looking down the hole here. So there's the soft palate right there. Hard palate starts right about there. So our stenosis is going to be fairly far caudal. Back here, I might almost be able to see it just by reflection of the soft palate back here. Can we get our Gelpia retractors? And my bipolar cautery, please. So the stenosis is going to be right about there, I think. Gelpies, both sets, the little wire ones and then the bigger ones. Cautery is on. Yep, all good. Yep. All right, so There's a tiny little hole to work in. All right, so I'm through the stenosis there. Move that out of the way for me, please. All right, so I've gone past the stenosis now. I'm just going to open that up a little bit more. So that's completely open now. And that's the nasopharynx up in here. So can I get some 4.0 PDS, please? I'm just going to make a little stay suture so I can retract that cranial a little bit, just so I can open up the, or remove the webbing in there. So the anesthetic protocol is, what do we use for pre-med ACE methadone? Fentanyl, so fentanyl midazolam for pre-med, alfaxan for induction, and then just ISO. And then we've got what kind of CRI, say? Fentanyl CRI as well. And then we've done a nerve block of the maxillary nerves, infraorbital nerves. Can I get bipolar turned up to 30 or 20, please? Can we get some 4x4s, or just regular gauze swabs, please? I'm just trying to remove some of that webbed tissue here. And the concern with this is that it's going to recur. So I'm trying to use judicious use of electrocautery, because electrocautery induces constriction. Can I get about a ml of depomedrol, please? And I'm going to inject some depomedrol. Into the area to try to reduce, so you'll have to get that from the pharmacy. So inject some depomedrol to try to reduce scar tissue formation here. See how that's going to come across to heal or to suture. Just waiting for a depomedrol. I came a little bit over to the other side, so my incision is not entirely midline. I don't think that causes any problem. So just waiting for that depomedrol. What is the smallest Vicryl that we have? I like to use Vicryl in the mouth just because it's softer and less likely to be irritating, but if I can't find any appropriately sized Vicryl, I'll use some PDS. 25, please. We'll draw it up with a 22, and then we'll inject it with a 25. It's about a mil. Okay. Yeah, that'll be too big. I'll just use my 4.0. So I'm just going to close this up in one layer. You know what? I'm going to bury my suture so it's not so irritating. Tiny little hole to work in. And we may consider putting a stent in this in the future if we have recurrence, and I would use a lined stent as opposed to an unlined stent. Cutting out my stay suture now. And I'm going to have Jason retract cranially. Just make sure your hand's not in the way of the screen. All good? Honestly, it wouldn't be the worst thing in the world if this dehisced and just left an oronasal fistula caudally, because it's far enough caudal that it's not going to cause any major problems, I don't think. Let's retract on that for me, please. This is one situation where it can help to put your needle in crooked in your needle driver. I'm a big proponent of always putting your needle in perfectly straight. But because we're suturing in a small setting, you can see that my needle is not perfectly straight, so I have it canted out to the outside like this for my far bite. And we're going to carefully place the suture, lay the loop down when we pull it tight, and then when I'm going to pass my next suture, I'm putting the needle crooked in the other direction so that I can kind of reach in and hook it underneath the soft palate. Give me some tension on that for me, please. I need that elevated a little bit, please. I'm going to try to get my knot inside the nasopharynx rather than the oropharynx. Okay. Hold on to that up there, please. Relax a little bit, please. Relax, please. So now all three ends are inside the nasopharynx. And if everything goes to plan, the knot's not going to be visible in the oral cavity. Okay, so I'll just cut the long end. And I'll pass that underneath. Try to invert that knot so it's all the way up in the nasopharynx. Just like that. All right, so that's what it looks like now, and hopefully that stricture has been resolved. That's the suture line, which is a little bit crooked, and if it recurs, we'll probably come in and put in a stent going from the nostril going caudally. So that's pretty much it. If you guys have any questions, please feel free to post them in the messages, and don't forget to subscribe, and hopefully I'll be streaming something else later on today. So thanks for watching, and we will talk to you soon.